I was in Sussex, so
it was Kent, isn't it?
yeah, it's gorgeous down there.
So you are looking at me as if the weather wasn't that great, was it not?
It's moisty.
Oh, did you? Oh.
It was very bright. Yeah.
Yeah, I needed to as well, but I didn't. So no.
You're all right now. Right. Okay, great. If I can just welcome everybody then a bit late to the Health and Adult Social Care Overview and Scrutiny Committee. The IT issues have been ironed out now, so I need to just inform everybody before the meeting that it is being live streamed and recorded. Item 1 on the agenda is apologies for absence. Do we have any apologies for absence?
Not that I'm aware of, Chair.
Sorry?
Not that I'm aware of, Chair.
No, I know Roy Allcroft did actually send his apologies in. Okay. Moving on then, disclosable pecuniary interests. Are there any such interests to be disclosed? If you do think of anything as we're going through the agenda, if you can indicate and leave the room. Minutes of the last meeting, item 3 on the agenda. Let me just find those. We all seen a copy of the minutes. They were sent out late. Are we happy that they're signed as a true and accurate copy? It's moved by Gerald, seconded by Jeff. All in favour? Right, thank you.
Sorry. Pretty sure I was there.
I'm pretty sure you were there as well. Right, we shall make sure that correction is added. Okay, thank you, Heather. Right, item 4, public question time. There are no public questions. Item 5, member questions. There's one member question from David Vasma. Councillor Vasma has not been able to attend, so the response to that, his question, we shall send to him and copy it to members of the committee.
Do you have a copy of the question as well?
Copy of the question as well, certainly, yeah.
Chair, there was another question as well submitted by Councillor Halliday, which regrettably we were unable to process in time, so we will carry that forward and present the question and answer at the next meeting too.
Fine, thank you. Item 5, review of 111 services, and Sam Tilley is attending via Teams. Also Sharon Clennell and Craig Lovett. So if we can move on to that. Who's actually presenting?
Oh, I'm on mute, sorry. Can everybody see me?
You can hear.
No, we've got the presentation. We can see the presentation, but we can't see you, but we can hear you.
Oh, okay, thank you. So first of all, unfortunately, Sam Tilley has been called away to an urgent meeting due to the pressures on the system at the moment. So there is myself, there is Sunil Rakandalia, who is representing Sam, and Craig Lovett that will be presenting as part of this. So first of all, thank you and morning to you all. Thank you for giving us this opportunity to provide an update on the 111 service in Shropshire and Salford. Next slide, please. The layout is, I've covered the introductions. I'll provide an update of the NHS 111 programme to date. Craig will then provide an update on the performance. We will then give you an overview, a high-level overview of our next steps, and then we'll be able to take questions from the committee. Is that okay with everyone?
Yeah, that's fine. Thank you.
Thank you. Next slide, please. So, as you're aware, in December 2020, Shropshire, Salford and Wrekin, as part of a national mandate, collaboratively successfully implemented the NHS 111 First programme. We implemented it with a controlled cohort to prevent any additional pressures on the system, and also to manage inappropriate demand on the system. We implemented it in a staged way, really. We went with 111 directly bookable appointments into our ED departments, SDEC, which is same day emergency care, our minor injuries unit, so the 4 across Shropshire. We did it in the stage way because we wanted to reduce the risk of increasing pressure on the services. So the staged implementation meant that we did 2 directly bookable appointments at each site per day. Part of the implementation also covered our urgent treatment centres, which some of you will know are co-located with our ED departments. Since the launch, our urgent treatment centres have progressed to having 14 appointments per day, and that was from March 21. NHS 111, the ability to book in, to be able to book patients that were clinically appropriate into our GP practices, that's been enabled across all GP practices across Shropshire and Salford. Practices currently release 1 appointment per 500 registered population, and that's for those patients. So that's just to clarify, those patients that are deemed by the NHS 111 pathways that they can be seen by GP, so they don't need to go to ED, and that's in hours only. The connection has been enabled between NHS 111 and the emergency care data set. That is, and Craig is the data guru, so Craig might be able to provide a bit more information on that afterwards. It's the national emergency care data set that allows us to identify patients that have attended ED within a 24 hours period from on. So what we can do is we can do an audit and actually try and understand the bigger picture. We've also seen a steady increase in the number of 111 booked appointments available in the urgent treatment centres, as I've alluded to previously, and GP practices since the launch. The number of ED appointments that are being booked by 111 is consistent, and also it's reassuring to know that the attendance for the patients, once they've been told that they've been booked into ED, that the attendance rate is high. Same day emergency care, so 111 referrals into same day emergency care. The numbers are relatively low, but we are working with staff to improve this. We've recently enabled paramedic access to be able to book into same day emergency care. Utilisation on our counties for MIU units is low. We are, as a system, reviewing the minor injury service offer to try and improve the utilisation of those appointments. March to April this year, we conducted with Healthwatch a survey for the patients of Shropshire and Salford. The numbers that we received were approximately, I think, around the 70 mark, We would have liked more, but what that told us was that in the majority of patients had said that their experience of 111 and NHS 111 first was in the main quite good. We also conducted a staff survey at our acute hospitals and to ask them really for their advice on whether there was any efficiencies, any improvements on the service that they could see that we could make. Unfortunately, we only had 7 people respond. We have, thanks to Craig, a robust data monitoring recording process in place, and that's been cited as an exemplar by the region. Next slide, please. I will now pass you over to Craig, who will give you an update on the performance to date.
Good morning all, hope you're well. Thanks again for allowing us the opportunity to talk through the data with you. The snapshot that we've just pulled together here is just an overview of where we believe some of the key measures are, but just to ensure confidence in what we are monitoring. As a system, we constantly review 111 ambulance ED data just for understanding of trends or changes in behaviour, and understanding the outcomes, including benchmarking against some of our regional partners. But just as an overview, we thought we'd go through some of these key measures with you. So our top left chart on screen at the moment is the NHS 111 cases triage per 1,000 population. So we always use a weighted population measure just to allow for our consistent benchmarking across both our CCGs locally and looking at the wider patch. As you can see on screen there by the top blue line, and this is an historic trend, that the usage of NHS 111 overall by Telford.
Sharon, hi, just one moment, please.
Yeah, sorry, Craig. I was just wondering, it's a very, very busy slide, this one, and it's difficult to actually see the items that you're talking about. Is it possible to zoom in on each of the key measures as you're talking about them? Because as it stands at the moment, it's just, it's a very, very busy slide that we can't really see clearly.
Okay, I'm not presenting. So,
Craig,
yes.
Sorry, can I just interject? Yeah, that has been brought to our attention. Unfortunately, we're not able to present. So I know that Daniel, there you go. Daniel kindly put them onto bigger slides for us. Thank you.
Yeah. Craig, I think these are in a fairly random order at the moment, so I put them on to individual slides for you. So if you can talk to the slide that I present each time, I think that provides a much clearer image then for the people attending the meeting. Is that okay with you?
Absolutely fine. If everybody else is happy that there might be some obviously misalignment, but I will talk to the sides, it's fine by myself.
Okay, then I'll put the first one on the screen for you now.
Okay, so this chart is relevant to the GP Connect information that Sharon alluded to, and this is where the practices do require to release those slots to general practice, to release them to NHS 111 for utilisation. So there has been some collaborative working with NHSE and NHS Digital partners just to improve how our system utilisation of those released appointments is conducted. As you can see on the screen here, that through from September 20, we've seen a significant increase in the amount of appointments that are actually utilised and booked by NHS 111. The utilisation overall continues to improve as, like I said, we connect in with both NHS Digital and our GP practices direct. If you can go to the next slide for me, please. So just this goes back to my previous conversation. So this is the chart that alludes to the overall usage of NHS 111 by registered population per 1,000 population. Historically, Telford and Wrekin, which is the solid blue line at the top, have had a much greater use of NHS 111 overall. Our Shropshire registered population, as you can see by the solid red line, is lower. However, the green line is reviewing all of our regional partners come together that are actually offered and serviced by the West Midlands Ambulance 111 service for ourselves. They have actually had a bigger increase proportionally. You can't see it as clearly on here because these are actual measures, but proportionally during the COVID impact. And you can see how the green dotted line has moved away from what was the trend similar to Shropshire. Obviously, this doesn't give us a clear, definite response or thought process on who we are monitoring. So we have used this and then done more granular work to see who is, and by registered practice, the population that are using NHS 111. But this is just an overall benchmark report that we use. Go to the next slide, please. And then perfectly into this. So this chart just shows you, and I know the practices aren't there, but this shows you the variance by all of the practices across Shropshire, Telford and Wrekin in the utilisation of NHS 111 overall. And as you can see there is quite considerable difference between some of our smaller practices that tend to be more rural based in access to 111, and then our urban younger population practices to the far right of the chart that have extremely high utilisation of NHS 111. And what we have started already is a piece of work alongside these practices that are very, very high users to understand the outcome of their usage and to understand why the population of that practice are using them in the first place. So that work has already started with our practices. And next slide, please. Okay, so two of the key measures from NHS 111 are the ambulance disposition rate. These are reviewed obviously locally, regionally and nationally, and the A&E recommendation rate, so the bottom charts. So historically, we've seen that Shropshire, Telford and Wrekin do tend to be on the lower part, and the bottom chart you're seeing on screen now, on the A&E recommendation. So we're seeing a lower, so that is the percentage of cases that call NHS 111 that result in being recommended to attend an urgent care provider and A&E recommendation. And we believe that directly links to where we are seeing a increased outcome in the proportion of patients that are being redirected back to practice. Hence, that supports the work that we're doing direct with practice on patient behaviour. And the next slide, please. This is just an overview and part of the measure impact that Sharon alluded to that we have for the 111 programme. And this reviews the period since NHS 111 launch. So the top two charts, I can appreciate these are quite busy. The top two charts are showing our unheralded attendances at our two ED departments, PRH top left, Royal Shrewsbury top right. And our unheralded population was the target audience of the NHS 111 first programme of work, where the aim was to reduce those patients that were attending an ED department without prior intervention or seeking any further health advice before doing so, and more commonly for more minor reasons for attendance. And as we can see, actually, since April, we've seen a notable increase. So that's around about mid-chart on what you're seeing there. A notable increase in the unheralded attendances at both departments, most notably at Princess Royal Hospital. And this is supporting the work then that we're doing in reviewing emergency care, attendance, the attendance type and the outcome of emergency care. Now, your bottom two charts there show the impact or the change in behaviour from NHS 111. So on the bottom left chart, Princess Royal Hospital, we can see some increase in the number of cases that are actually presenting at Princess Royal ED as a result of speaking to 111 first. So that does align with and as expected to the introduction of the 111 programme. Now Royal Shrewsbury Hospital on the bottom right, even though it looks much lower, is on the same level axis as Princess Royal, and that means that we have seen very little impact and change in the 111 activity coming through, and again would align with the Shropshire County usage of 111 overall. Next slide, please. So finally, these are just a couple of slides that we're going to go to now, and charts that are taken from the review pack for the 111 first template, and this is just showing the capture of the booked appointments from NHS 111. So most notably, you can see in the middle of the screen, which is Princess Royal UTC and Royal Shrewsbury UTC. Since we've increased the availability of appointments, the 111 usage has increased, and actually we've had very, very good attendance rates of both the of those services available there. Well, again, on screen here, we can see the blue charts just show what is available. So we can still increase, where appropriate, the amount of appointments that are actually taken and booked by 111. However, those that are booked do have very good utilisation rates, which should be on our next screen, next slide, if you will. Here we go. So those that are booked, we can see quite good success across the whole system. Regardless of the amount of appointments that are booked, that we have very good attendance rates on those. So even though we've increased both the PRH and RSH UTC, you can see that we're at 89.4 and 92.5 attendance rates. So that just means that we have very, very good attendance, and the appointments are being appropriately used and attended so far. I think that actually concludes the slides, but just with regards to a comment that Sharon mentioned about the joined up 111 and the emergency care data set, that piece of work allows us to see where there is an outcome from NHS 111 and what did the patient choose. So, for example, if a patient was advised to attend Princess Royal Emergency Department, we can see within a 24-hour period whether they did attend or they chose not to. Or more importantly, we can see if a patient was referred maybe to attend back to their GP practice, and did they attend ED or not. So that intelligence that's providing us is enabling us to do a more in-depth work again with patients' practices and trying to look at their behaviours. Thank you very much. I think we're back to Sharon for the next steps.
Apologies. Thanks, Craig. So the next slide provides an update of all the work that's ongoing. It's not, this list isn't exhaustive, and it's just a high level summary. So following on from what Craig has mentioned about the high usage of 111, I think it's important to remember that NHS 111 first is for those patients that have an urgent medical need. Because of the high demand, particularly like Craig's alluded to from the Salford side, we're working with primary care colleagues to look at patient behaviour and also their access to GP appointments in hours. We're working with the CCG primary care team to look at the practices with the patients that are the high users of 111, to look to develop action plans to try and mitigate some of that demand. We're also working with practices around maximising the utilisation of their slots. So, as I've alluded to previously, practices release one slot per 500 registered population. We found that not all those slots across all the practices are being used. Part of the reason for that, and Craig, please feel free to add in, chip in, is that it's very, what we find is that Craig, can you support?
Sorry, Sharon, refer back to that again. Sorry, what are you? Sorry, sorry.
I'm talking about the low utilisation of some of the slots in some of the practices and some of the data work that we've done previously to try and determine why that is. Okay, so yeah, as Sharon mentioned, so the utilisation of the book slots is very, very dependent on the overall use of NHS 111. So we have some rural practices that don't use and access NHS 111 very much at all. Have a very low usage overall, and the outcome of that is that they don't normally need much
There's not much need for those appointments then to be booked back into their own practice, and it could coincide nicely with the access direct to the practice, or literally how the practice is set up for a utilisation of all services that they offer. And then on the opposite end of the scale, then we have practices that have very, very, very high usage of NHS 111. And subsequently, the outcome of those appointments may mean an increased need for primary care support. And then subsequently, then the utilisation of those slots then is actually taken up. And an extended piece of work with the practices that we're doing is allowing the practices, giving them greater understanding that any appointments that are not used, they can utilise themselves directly for the patients. So this is a new piece of work that's been done in communications out to the practice, which, like I said, it means that we are improving overall usage of any release appointments, either direct by 111 or by the practices themselves if they are unused. Hope that's okay, Sharon.
Yeah, no, that's great. Thank you. In addition to that, we've also done a free refresh of the communications and sent with primary care. And that's around the messaging for patients about alternatives to GP practices, for instance, going to the pharmacy, self-help, etc. And also what I've alluded to previously about what 111 First is for. It's for those patients that have an urgent need. SAF are reviewing their data to improve the availability of the urgent treatment centres and looking to improve the triage based on current data patterns around attendance. We're working with our acute provider to try to increase the number of slots available to 111 for them to book into. We've looked at the ED attendances overall over all the conditions. One of the areas that is particularly high are those patients that are attending ED with a soft tissue injury wound. That currently stands at around 36% of all ED activity. As a system, we're working with the community hospitals, the urgent treatment centre to look at alternative provisions, because obviously that's like a third of the activity going to ED. There is work ongoing to look at increasing the usage of the NHS Ask app. That is being led by SAF. That would provide patients with the waiting times for A&E and the MIUs, etc. So we're hoping that if patients are more informed and those that could be seen elsewhere, if we could educate patients and provide them with this information, they may choose to go to wait for their GP practice, go to a pharmacy rather than wait up to 4 hours if it's not urgent in an A&E department. There's ongoing review and maintenance of the 111 directory of services. What that is I can only liken it to the yellow pages of all the services available in Shropshire. We're specifically looking at the minor injury units, again, to increase the utilisation of the MIUs and to see if there's any, for instance, the soft tissue, is there a possibility that that could go to the MIUs, and is there something on the directory that we've missed which is not allowing 111 to signpost patients to the MIUs. West Midlands Ambulance, as I alluded to before, now have the ability to directly book into same-day emergency care, and they're doing that via the Care Coordination Centre based within Shropshire. Healthwatch survey part 2. So following the first Healthwatch survey, which I alluded to in the first slide, we're planning to run another survey from October. The lessons learned from the first one is one of the reasons we feel that the numbers were low is that the various forms that patients and staff were able to feed back on were very limited. So incorporated in that is a system-wide communication strategy, which is also in development. And we're also going to be doing a targeted piece of work around the communication and messaging for patients about the minor injury units and their offer to try and increase the utilisation. We're working with regional NHSEI colleagues, and they're supporting us in looking at missed opportunities in the system. So it's very easy for us to get stuck in and maybe miss something that potentially could make a difference. So we're being supported by that to try and reduce the unprecedented demand. And also, all of this kind of comes together. There is a dedicated system-wide 111 programme which is looking at all these work streams as part of the Shropshire, Salford and Wrekin Urgent and Emergency Improvement Programme. Next slide, please. Thank you. And that's the end of our presentation. So is there any questions, please?
Right, thank you very much, both Sharon and Craig, for those that presentation. Before I open up for other questions, obviously, particularly from the last slide, the difference, I think there's a misunderstanding with a lot of people between the difference between an emergency department and an MIU as to what offer they give. I just wonder if you could just explain what the difference, the main difference is between an ED, what they provide that an MIU doesn't.
So an emergency department, so those are for patients that are critically ill, so life-threatening. Minor injuries are for those that aren't critically ill. So for instance, a classic would be a soft tissue injury. That would be appropriate for a minor injury. So it's not critical, it's not life-threatening. Obviously, the minor injury units, they have a criteria of patients that they see. What we're trying to do is, as I alluded to, is widen that offer, but minor injuries will never see patients that are life-threatening or have had, for example, a heart attack or have got rapid chest pain. Does that clarify it?
Yeah, yes. I think, as I say, I think a lot of people sort of won't use an MIU because they don't understand exactly what they do. They can provide sort of everything that an ED will provide, other than, as you say, the life-threatening conditions. So thank you for that. Right, open up to questioning. First question, Heather.
Thank you. I'm really interested in how you're working with the 111 system across border, because for many of us, well, the only ED actually is Shrewsbury, but if we're looking at MIUs, it's either travelling 20 or 25 miles for an MIU or 7 to Welshpool. So there are issues with all of that. Furthermore, when I have used, and it was just before COVID, 111, both in Scotland, but also then, well, not in Scotland, in Cumbria, but then again here in Shropshire, I was directed 1 to Scotland and 2 to Cardiff, and Cardiff have no idea where Cherbury is. So I'm concerned about the direction of patients. Furthermore, half of my division have Shropshire doctors and half have Welsh doctors. So where does the 111 system deal with that, and dealing with us who have Welsh doctors, me included, and how much dealing do you have, for instance, with a Montgomery practice or other practices? Because the same will be true in reverse for the Welsh patients who are registered with an English practice, both in Oswestry and in my division, across my division. So it's an interesting question. I've got a couple of others. Leave that one there, and then can I come back and do the others afterwards, or do you want them all now, Chair?
No.
Sorry, Sharon, yes, what were you?
No, I think if it's okay, it'd be helpful to take them one by one. So if I just break down the question. So in terms of the bordering you mentioned, sorry, I didn't quite catch your name.
I'm Councillor Heather Kidd. I'm Councillor for Cherbury and Worthing. We have one English practice in my division. Some of my division go to Bishop's Castle, and the rest go to Montgomery or Knighton. Okay.
So in terms of the border issue, so for Shropshire, Salford and Wrekin, yes, I take your point that we deal with patients that are registered with a Shropshire and Salford practice. You mentioned dealing with, did you say practices on the border?
Yes, I mean, my particular concern is when I rang, they asked me for my, well, they could see my phone number, which was an 01938 number, which is, and the postcode, both for, well, a large chunk is also a Welsh postcode, which means that you automatically get directed other places.
Okay. I'll be honest with you, Heather. I'm not quite sure why that happened, why you were signposted. Where were you signposted to?
Cardiff.
Cardiff. I can't quite understand why that's happened. So I don't have all the answers, I'm going to be honest. If I could ask you to send, if you would be willing to share that specific case, I will pick that up with the 111 region and find out why that happened. As
come back on that, it's just that I raised this before COVID, and of course we haven't had the opportunity.
Okay.
But the issue isn't that, it's the postcode and the phone number that gets picked up, and often you just get directed automatically. My brother-in-law, I might tell you, lives just outside Shropshire, and automatically, and actually, but probably is closer to Shrewsbury than I am, and he automatically goes through to the Welsh system, even though he's registered with a Bishop's Castle practice.
I mean, the 111 directory of services that I alluded to before, for those patients, particularly your brother-in-law and yourself, I don't have the answer why he's if he was signposted to Bishop's Castle, it will be potentially that his criteria, his condition could be seen by the MIUs in Bishop's Castle, by the MIU in Bishop's Castle. We accept as a system that our MIUs are spread across the county, and travelling and getting to the MIUs, whether it's financial or transport, is an issue. But again, that's part of our review of the MIU offer. But in those two cases, Heather, as I said, if you're willing to share, I'll take responsibility to look into those and come back to you directly.
I think the issue here with my brother-in-law was they ended up having to have an ambulance from Aberystwyth, which is an hour and a half away.
Yes.
There are and that was all through 111. So there are issues on the border, and I raised this before COVID because it was happening before COVID, if we remember. Through the committee, we did this, and actually we were assured that these things would not happen. The issue around Bishop's Castle is they do not have an MIU there. The nearest is Ludlow or will be Shrewsbury. So actually pinpointing where people are and where their GP practices are is really important, and it obviously was not working, certainly when they needed an ambulance, but certainly not 2 years ago, and I was just needing reassurance that somebody had actually improved it over the time.
Well, I mean, I can't comment on this previous discussions, but I mean, I can apologise for your experience, and like I said, without looking into it, I can't answer why specifically that's happened.
I think it's not about the specifics, it's about the principle of what happens along the border that I'm more concerned about, because if it's a little old lady of 80, she's going to get very confused. So I just needed, if you could look into what happens along the border, that would be really good.
Yeah, I think, Sharon, I think what the issue is 111, if you're using purely telephone exchange number or a postcode, it isn't specific to the area which is in question. I think the issue is that you need to break down the postcodes more, because just because it isn't a Shropshire postcode doesn't mean to say they don't live in Shropshire. I think that's possibly what the issue is here with 111. So I think that's something that actually does need to be looked into. Okay.
Okay, thank you.
Okay. Heather, you had another question or two?
Yeah. Another, I was interested, you only had 7 responses, and are you looking into why you only had 7 responses to this review that you did on one thing? Because that may be a communication problem, and so while you're looking at communications, which you said you were going to do, that would be great. But the other issue is when we looked at the difference between rural and urban, which is significantly different, I'd just like to throw in the pond that actually we know that less people in rural areas call 999 for an ambulance as well. It's something to do with the way people in rural areas work alongside their GP practices and so on. We've had the ambulance service that regularly tell us that rural areas do not call for an ambulance as often as the urban areas do, and it seems to sit with this use of 111 as well, so it might be worth investigating that alongside.
Yes, so thank you, Heather. So if I take the first point first, in terms of the low numbers, as I said, one of the lessons learned from doing the survey, both the Healthwatch patient one and the staff survey, was the variety of forms that people were able to feed back through. So what we will be doing is widening that aspect and monitoring those the responses to ensure that we've got a good uptake. In terms of the rural low demand on the ambulance and 111 service, as I've already said, part of our ongoing work is looking at the reasons behind, why patients are using 111, those areas, and also looking at patient behaviour and the reasons why they're using 111 so much. Does that answer your question?
Not really, but yes.
Right, thank you. I've got another 2 questioners at the moment. I've got Julia Buckley and Kate Halliday. So Julia, who's remote, if you can ask your question.
Thank you. I'm Councillor Julia Buckley from Bridge North West and Tasley. I just wanted to know how this review relates to or could be impacted by the rather sudden review by the ambulance service, which is looking to potentially close down some of the rural ambulance stations, which are sort of, those rest points where the ambulances can have a break between bookings and then tend to deal with inquiries where they are located. And then sort of a related point really is just my concern about how the resources are aligned to these different services based on population density. So I think you mentioned that the number of 111 appointments released per surgery equates to 1 per 500 patients. So that assumption is that where you have high population density, that would be proportionate to the number of emergency cases needed. But obviously in rural areas where we have an ageing population, so on average 9 years older, I find it hard to believe that we wouldn't have a higher proportion relative, and that we shouldn't be penalised because our population is so thinly spread out in the rural areas. So my plea would be, when these services are being reviewed, if population density is going to be continued to be used as a measure by which services are sort of concentrated, could you also please think about the impact for rural areas and just consider the other sort of social factors in rural areas, which means that where absolute numbers may be lower, you might not have 10,000 people in a village, but the number of the requirements of those people could in fact be disproportionately higher. So let's not have everything centralised and be removing these resources where actually need is probably higher. They're not just older with more complications, they often are restricted by mobility, so they're probably more dependent on things like emergency ambulance care because they probably can't drive themselves. So could that be considered in some way in the distribution? Thank you.
Thanks, Julia. That's really your latter point. That's a really interesting point. So the reason, if I just give you the reason of where we are, the one appointment for 500 per 500 registered patients, that was a national directive. And so we've done what the ask was of us, but actually your points are very valid, and that is something that I will take away, and I will speak to our regional commissioners about that point and our regional NHSEI colleagues. Is that okay? I can't give you the answer now, but it is a really interesting point. Craig, I don't know whether you can advise, because we've recently recruited in our BI team who was working partly with the council and the CCG, and one of the areas they're looking at population, local health population density and requirements. Craig?
Yes, so probably just referring quickly back to Julie's original comment as well around the appointment releases per 500 population. Yeah, completely agree with the sentiments about possible need is very different in regards into the age profile. However, what we've seen, and as we mentioned in the data, is the actual, if we look at the smaller, more rural practices, and yes, they've only got to release the same 1 per 500 population, and that might look like anything from 4 appointments to around about 4 appointments or 6 appointments per week only. The utilisation of them is very low. So if they're releasing 4 or 6, only 2 or 3 might be used, if that. And that's because then the NHS 111 usage by the population in the rural areas is much lower. As you've alluded to, they manage their health very differently, and that's something that we really want to learn. And that links into Sharon's point. Yes, we have just appointed 2 new population health management senior analysts that actually for the first time work collaboratively between CCG for health and the local authority. So over the coming months, they will be reviewing and accessing data in different ways than we've ever seen before by utilising local authority access and health information to try and form better a better understanding of behaviours, trends and services that are available. And that includes looking at health inequalities as well for some of our deprived areas that are very highly populated. So yeah, it's an exciting piece of work going forward, and yeah, we will come back to you as we get some improved understanding.
Thank you. That's really interesting about those new analysts, and I hope that perhaps one of those could come and present to us when they're a bit further on. You know, as a rural county, it's so important to us that we keep pushing that message back. Exactly as you say, that all our services are experienced and differently, and therefore need to be managed differently. So that pushback against the national message. So I really welcome those new analysts. I hope they could be invited to come and speak to this committee because they sound really interesting.
Well done, Julia. Thank you.
Yeah, I'll just make one other comment as well with regards to Julia's question. The question of the ambulance service, that is obviously a completely separate service to the 111, and we are actually looking into the ambulance service with regards to the closure of some of the stations at the joint health and overview scrutiny. Right, next question, Kate. Sorry.
On the same question. When an ambulance if it's an ambulance locally, if it's a Whitchurch ambulance station, Oswestry ambulance, whenever they go up on there, they have to go to Shrewsbury anyway, don't they? Each day to clock on from Shrewsbury.
I'm not sure of that.
And it's completely restocked with the stuff they've got.
Councillor Dakin, I would suggest you save these questions for the Joint Health Committee. The officers here will not be able to answer your questions, I'm afraid. This is a completely different commission service.
When we're discussing about the ambulance stations being moved, this is one of the reasons.
No, we're discussing that at the Joint Health and Overview Scrutiny. We're not discussing that now because it's a separate service to the 111 service.
Well, in that case, we take it forward from the Joint Committee.
Yes. Yeah, we are taking those questions forward to the Joint Committee. Yeah. Sorry, Kate.
Thank you, Chair. Yeah, I have two questions. The first was, it says the utilisation of the county's 4 minor injury units is low for 111 bookings. And, obviously, you've also highlighted in your presentation the fact that I think you said 36% of people turning up at ED have soft tissue injuries. So clearly there's an issue there. And is this because people with soft tissue injuries are just bypassing the 111 system and just going straight to A&E? Or is it that there's an issue with the triage at the 111 point? And then it's kind of a similar question, so I'll just pop it in as well. You say that the same day emergency care referral numbers into this service are low. Could you just explain that a little bit more in terms of exactly what is available in Shropshire for same day emergency care? And when you said the referral numbers into the service are low, do you mean referral numbers into 111, or do you mean 111 referrals into same day emergency care? Thank you.
I'll pick that one up if that's okay, Sharon. So in regards to your first point about the soft tissue injuries, so yes, soft tissue and wound groupings do appear on the NHS 111 DOS. So if persons are calling to get advice, they will get an appropriate outcome, whether that needs to be a more minor GP practice or whether it does actually come out with a recommendation to ED. However, with soft tissue and wound, just thinking about natural thought process as a person, as a parent, as a patient, as anything, it is naturally probably likely that the person will want to present and get more urgent care access. And that would include attending ED, so or the UTCs, which is the urgent treatment centres co-located. With that in mind, yes, we are exploring, because there's a high proportion of people attending and that may need the most minor of interventions. So not necessarily increasing those cases through NHS 111, but thinking about overall of 111 and patient population behaviours for a soft tissue and wound is going to be a primary focus area. What could be looked to deliver elsewhere, or what could be done regarding the redirection to attend the minor injury units, as we've spoken about. So the soft tissue injuries it's a focus area that we are hoping to improve and look at. And then with regard, go on, sorry, Sharon.
Sorry, I was just going to say, in addition to that, I think it's important to mention, so the offer that of the service for the MIUs that's out there is inconsistent. So they don't all open at the same time. They don't all close at the same time. They're not open as long as the ED departments, so, or A&E. So if somebody has a soft tissue injury at 9 o'clock in the evening, the MIUs is not an option. So that's one area as part of the review that we're looking at. We know that in the MIUs, their X-ray service as well is not open all of the day. So again, any patients that need an X-ray at the MIUs, they would only be sent there if the X-rays were available. So that's just to add some of the background that's all feeding into the review. Thank you, Craig.
Okay. And then I'll just refer back to the SDEC offering that you mentioned as well. Our conversation here and delivery today is around the NHS 111 services, and we have reviewed the usage of SDEC from 111. Regionally, nationally, it is not a highly used outcome from NHS 111, and that's clinically appropriately that it's not massively used. However, the utilisation of the ones that are appropriate, we have seen that obviously NHS 111 are sending them through to services available. However, the way that the Shropshire service was set up was for the recommendations to go through ShropDoc, and ShropDoc have clinically been able to support the patients that have actually helped support them not needing to attend the SDEC departments. So by having that third party involvement where they can book direct into SDEC or whether they can clinically review has actually helped with reduce the demand going into the department direct. So SDEC as an overall service is being utilised, and as Sharon has said, that we have now on board the access directly for the ambulance crews to do that. But from a 111 aspect, it is locally and nationally a low service, and as mentioned, we've got ShropDoc that helps support that clinical model.
Okay, thank you.
Right, now Tracy, you've got a question.
Thank you. Tracy Huffer, I'm counsellor for Ludlow East. With regard to I'm going back to soft tissue injury patients. I probably should declare at this point that I work at a GP practice in Ludlow. We often have lots of inappropriate patients turn up inappropriately for a soft tissue injury, and that's mainly because they want the quickest option. They complain often that the 111 system, the triage takes too long, and patients have waited up to 40 to 60 minutes for an hour for a GP callback. Patients in rural locations are not going to wait that long because they see that then they might have an hour's journey to RSH or Princess Royal. So often they attend a GP surgery with a tissue wound injury or some other problem. And as you can appreciate, the nursing team have their slots booked fully every day. So we often then have to try and steer that person up to minor injuries unit or somewhere else. So I'm glad to see that you're going to improve the amount of appointments with minor injuries. But again, as Kate said, a lot of these minor injuries units are not open. Some have we've even had cases when they've been closed all day at the last minute, so patients cannot attend there. So my main issue is really the feedback I'm getting from patients that the triage system is too long, that patients rurally, I think Craig mentioned that they manage their health issues well themselves. Yes, they do, but the main thing is they will not use 111 because the system is too long, and so they often just jump in a car, go up to Princess Royal or RSH themselves, because they're not prepared to wait that long, especially if they're elderly. They panic, they've got soft tissue injury, they're bleeding, so they either turn up with a great big wad of tissue around their leg at the GP practice, or they just get, or a neighbour takes them up. And I still think there is an issue with the 111 system and the triage just taking too long. And I just would be like to hear if there's any ways that you think you can improve that, or if you had feedback to confirm that. Thank you.
Okay, thank you. So the 111 service, patients are directed through nationally mandated NHS 111 pathways. So there is, from what I understand, a national group that does look at the pathways. Again, in terms of timing and the waits for 111, there is an opportunity. I don't know if you're aware of the healthcare professional feedback forms, that whereby, so what we need is evidence of the cases, because unless we know what's happening out there, we can't attempt to address them. So all practices have access to those and have a process to send those through to 111. In terms of patients not choosing to wait, my feedback is that since July, particularly, and COVID, the NHS, as you know, is on significant pressure, both in primary care and secondary care. If I was a patient, and understandably, you know, patients have different needs, they have different expectations, but currently, if a patient was to turn up with a soft injury, and okay, I'm not clinical, so, but if it was a basic injury, the wait in A&E at both sites could be phenomenally long. So yes, half an hour to and the pathways is a long process. I accept that, but also, I suppose on the flip side, they could be waiting a lot longer than that in our A&E departments. So I take your point on board, and it is something that I will look into with our NHSEI regional teams to see if there's any work that they're doing to look at the 111 pathways. And we also have our regional commissioners, so we have monthly meetings, so I will also raise it through them. Craig, do we receive waiting times, the waiting times for calls from 111 in your ECDS data or anything?
It wouldn't be in the emergency care data set, it would be in the 111 data that we have. So again, we can review the contract packs. With that in mind, normally the provision is at an overall level. However, looking at the, we should be able to, from 111 raw data, be a bit more granular.
That would be really, that'd be really helpful. Is that okay? And then we can feed back to you, bring an update back to you on our findings.
Yeah, that's fine, thank you. I've got David and then Heather. David.
You mentioned that you've got some regular users of 111, and I was just wondering what percentage is that? Is it a number that's significant? And have you any idea how many are vexatious? And what are you going to do? You say you're going to have a survey to find out the reasons. Have you any special ways to find out what the problems are here and how to avoid them or remove them?
Craig, do you, right, yep. So on both sides of the county, we have a frequent attenders service, and we work with SAF. There are monthly reports that Craig and his team, is that correct, Craig? That the team pull from the hospital of the I think it's the top 100 attenders. In Salford, we have the service provided by Court Street Medical Practice. So they actually work with the hospital to look at those frequent attenders and try and work with them to prevent them attending and trying to find out the reason. One of the biggest issues, if I'm honest, is that the patients themselves have got to be willing to engage. In Shropshire County, it works slightly different, but the same ethos applies. There is a report going to our strategic committee in October about pulling the two services together, but primarily the purpose of the service is to look at those frequent users, try and find out why, and work with, it could be the community teams, it could be physio, it could be the hospital, to try and find out what's behind the reasons, where do they need support. But again, one of the reliances of the service is on the engagement from the patients. Craig, again, does pull together a frequent service data pack. Craig, I don't know if you can provide any more information on that at the moment.
Okay, so twofold. So the part that obviously Sharon's alluding to is the high intensity service user program reviews the ED attenders. It reviews those that are associated with short length of stay in hospital and also increased use of the ambulance service. The national mandate for that service does not include capturing NHS 111 usage. However, as a separate programme of work, and as part of what we mentioned, how we're going to be working with the GP practices, what we're able to do to support the practices in understanding their overall population behaviour and more specifically certain users, we create a bespoke granular level pack for the practices that looks at their call rates, it looks at their utilisation of services, their outcome. And then also we're able to provide them the practices, any patients that are very, very high users of NHS 111 specifically, and the outcome of that. So it might be, and just for confirmation for yourselves, we as CCG employees do not get access to and not allowed to see patient identifiable information. However, we are able to provide support to practices, ways in which they can access their own practice systems to re-identify these patients. So, for example, patient X might be using NHS 111 20 times per month and have a very, very minor outcome that might be closed on the phone or in some cases referred back to the GP practice. So that would then be useful for the practice then to understand that and converse with the patient to understand why they're doing so. Or oppositely, patient Y might have very high usage of NHS 111, be attending ED regularly, and then they might form part of the programme of work that Sharon's alluded to for the high intensity service user programme. So there's two pieces of work that are correlating alongside each other that does target patients that are increased users of different services.
Can I say thank you for that information? It's good to hear that something is being done to try and tackle the problem, but you still haven't said to me whether you've got any statistics to show how big the problem is.
Okay, so in regards to that, I mean, into actual numbers of calls into the service. So Telford averages around about 5,000 calls per month going into NHS 111, and Shropshire's is around about 6,000 calls per month. So we're talking about across the whole patch around about 11 to 12,000 calls per month going into NHS 111. So the stats on number of persons using it frequently is a very low proportion, very low, like under 1%. So rather than actually just think about those people as the statistic and overall pressure, we prefer to target those as individuals and just look at that patient specifically, which is done via, like I said, reviewing their records and then working with the practices to let them know. So rather than just thinking, yes, it is 0.5% of our population are high users because they've called upwards of 10 times, it's better for us to review the patient specifically of those that show frequent use.
Thank you for that.
Thank you. And Heather?
I'd quite like just to come back to this border issue. Listening to you, it seems that we have a hard border now, which is NHS England versus NHS Wales, and 111 one side and 111 the other. And I'm really concerned that the geography for residents in Shropshire means that they have long distances to go to MIUs, EDs, even for some of them their GPs. That actually we should be able to refer their Shropshire patients to the MIU in Welshpool or Knighton or wherever else there is along the border. And listening to you, we're just being Shropshire centric, and I presume the same thing is happening along the Staffordshire border. And so I'm really interested in these hard borders that seem to be appearing here, because actually people don't recognise them and patients need the best, quickest service. And I would just like to remind everybody that in rural areas, our mobile phone signal is chronic, many places. And so for many people, if you're relying on a mobile phone to ring 111, actually it's a pretty difficult operation, especially if you're an older person.
Okay, thank you, Heather. Yeah, I think it's a really tricky one. Take your point. I mean, fundamentally, patient care is at the heart of what we do. So that's what we're always striving to improve. I take on board the border issues. I don't think apologies if you feel that from what we've said, you know, that there's a hard line across the borders. Yes, Hereford and Worcester probably would have the same issues. So I don't have all the answers at the moment, Heather, but I'm quite happy to take that back as an issue and raise concerns and feed that back to you, because it is something locally that we need to, that I agree we need to be mindful of, and we need to make sure that, you know, we're addressing those concerns. Heather, if it's possible, would you either after this meeting be able to send me your email address so that I can make direct contact with you?
I have no problem with that, but I don't have your email either, so I'm hoping that Daniel can provide that.
Yeah, Daniel does have my email address, so I'm happy to start that conversation so that I quickly address or try and, you know, provide some assurance about those border issues.
Yeah, if we can make sure though that the conversation is between the whole of the, you know, the emails shared with the whole of the committee rather than just Heather as an individual. Okay. Right. Thank you, Gerald. You have a question.
I'm quite amazed at the low uptake for minor injuries on 111 at the local hospitals. Now, is it possible that that's because their opening times aren't long enough, and you won't go there because we can't get in?
Yeah, no, absolutely. That is why we're doing the review, is because of the inconsistent offer. There is also, as I said, we're fully aware that of the geographical locations of the MIUs. I'm not saying that we could shift and move them so, you know, they're closer to you know, to the more dense populations. They are where they are at the moment, but the review will include all of that and try and provide a consistent offer, and also which will include the opening times, their offer, and also look at why patients are choosing not to go there. And as I said again, we are fully aware, because of the geographical location of some of the MIUs, it's not always easy for patients to get there, for whether it be transport or financial reasons as well. So that's something else that we need to bear in mind when we carry out the review.
I don't have any trouble with the location. You got the locations in my case, but I just think that particularly at Whitchurch, the low take-home was amazing. There must be a reason for it. So,
and that, yeah.
Okay, thank you.
Right, well, if I can pass my thanks on to you, Sharon, and Craig. There's no further questions, so thank you for your presentation. I think you were probably thrown in at the deep end of it there, Sharon, because that wasn't here. So I'm assuming it was a last minute thing that you were selected, was it?
No, we plan to do it very much as a team effort, and I can only, I say, try and provide some assurance that we are working really, really hard. We are, we all work for the NHS because patients are at our heart, and we want to improve the services that are available. We don't have all the answers at the moment, but what we will take back from today is the concerns that have been raised and try and get back to you as soon as possible to address them. Thank you for inviting us to attend.
Thank you. Okay. Right, now we'll move on to item 6 on the agenda, which is independent living. Right, this is Stephanie, is it Steph? Yeah.
No.
They're via Teams as well. Sorry. Yeah. Sophie and you in here, and the rest via Teams. Great. Okay. Over to you then. Thank you.
So I think committee have had 2 really helpful briefings already in advance of this committee, just to kind of help members get informed before this important scrutiny agenda. So thank you very much. I had some really positive feedback from members about both briefings. So I think we'll hand over now to Michelle and to Steph, and I'm sure you've got some really important questions that you want to ask here this morning.
Shall I make a start then? Is that
okay?
Can we? It's a bit difficult because Steph's behind us.
Michelle, should we swap?
Yeah.
You can see you and I'll come and sit next.
Thank you. See, I'm all right because I can see you. Don't bother me. Maybe we should be stepping in a circle.
Thank you. So I think really, I'm not sure how I want to go about this. Obviously, the presentation's been delivered. I know quite a few faces were at the presentation, which was great. And between the presentation now, the only main question I had was around the assistive technology project and the age groups of the individuals who were accessing the technology. So I've got that information available, so I'll share that. And I guess really just to give you a little bit of an update of where we're at since, because it's an ever-changing situation that we're in at the moment. In relation to the assistive technology, when I did my presentation, I talked about the fact that the idea initially was to introduce that technology to support people with really quite complex needs, to present escalations in behaviour, and like I said in my presentation, we had some really successful results with that. Some individuals who've been really quite complex, who've been in long-stay hospital for quite some time, have managed to remain in the community with their support providers, and the assistive technology has been a part of that, being able to help them, change the way they communicate, because communication is such a huge
part for individuals if they don't quite understand what you're trying to talk to them about because their communication is limited and you're trying to do it verbally. It can really frustrate and upset them and make them anxious. So having those digital devices to show pictures and share communication in a different way has made a huge impact, which is fantastic. But we are now starting to talk to some of our providers because I'm sure you're all too aware of the situation we're in nationally at the moment around care provision and the lack of it, and that goes across the system, and that's across learning disabilities and autism as well, and mental health. So we're now reaching out to some of our providers. I think I said when we met last, I think we've got around 53 individuals receiving assistive technology at the moment, and we're looking at being able to reduce some of those visits where individuals can manage on their own. So we've just gone out to our provider market who are really struggling and said, you know, think about the schemes you've got where you've got individuals in who are now amazingly making their own lunches, making their own drinks and things because of that support and that access to that technology. And if providers have got properties in really similar locations, they've got an opportunity to maybe leave somebody on their own for a couple of hours at lunchtime and go and do a visit somewhere else where they might be short-staffed. So we're just getting that data back in at the moment, and one of our big providers is doing a piece of work on that and saying, yeah, absolutely, we can see an opportunity here. And this was the longer term goal for the assistive technology project. We didn't think we'd get there quite so quickly in terms of looking at reducing the care, but the crisis that we're in currently has kind of almost helped shape that naturally, but it's been a really positive outcome. So that's ongoing. So hopefully I'll be able to bring up some more data around that in maybe the next 6 months time to say, you know, how that's changed the type of support that individuals are receiving. So it's not just people all the time being in their home and infringing on their privacy. And so that's really positive. So that's ongoing. We've also, I presented in my presentation around our flexible contracting arrangement, and that's obviously around inviting more providers into the market because, again, we do lack providers with the right level of experience and expertise to support our more complex individuals. And sadly, as I described when we met last, we are seeing more and more complex individuals coming through the system, particularly young people out of long-stay hospitals, where we're jointly responsible to support those individuals with our health colleagues. So we reopened the flexible contracting arrangement application process for new providers, and that closed on the 1st of September, and we've had a further 16 applications, which is really positive from different providers. And therefore ourselves and Health and Region Council, because it's a joint piece of work if you remember, are currently evaluating those new applications, and hopefully then by the 1st of October we'll have some new providers coming into Shropshire and hopefully bringing some staff with them because that's obviously one of the key things. It's all very well entering into the market in Shropshire, but if there isn't the staff here, then that's also an issue. We're looking obviously at rates of pay for staff, and then that brings me on to the Care Cubed calculator that we are using now. We're still soft market testing that, particularly around residential placements of adults with learning disabilities, autism and mental health, to make sure that, you know, the amount of money that the individual staff are getting is being passported onto them, and that the on costs of the providers are manageable and sustainable to allow for that. We've got a situation at the moment where a provider's been successful in accessing a new service, but they're really struggling to recruit. So we've been supporting them with recruitment through our own social media channels within the local authority. We've got the families on board to support with that process as well for the loved ones who are going to be in that placement. But we've also talked to them about the hourly rate and, you know, are they, you know, is there anything they can do differently that we can support them with to allow them to offer a higher hourly rate to those staff that they're recruiting. So yes, I think those are probably the main updates since I delivered my briefing. And I don't know if anybody has got any questions at this stage based on that briefing or not.
Right. Thank you for that. Now, we all obviously attended the briefing, or those of us who didn't, because unfortunately I wasn't there. We did have them recorded, so has everybody actually seen the briefing or the recording of it? Either attended or seen it. That's great.
I'm afraid I haven't, but I've got a button to press to get the recordings. I want to remember.
Right.
Okay.
Yeah.
Did you send them to me?
Then Robert.
My chief officer might ask for that.
Yeah. Probably not actually, because they're about 0.5 gigabyte large usually, and they probably overwhelm everybody's email systems. I think, let me look into that. I think it might be an issue with regards to IT access. going forward. We might need to set you up with a Shropshire email address, I think, to allow you access. But let me look into that for you.
Discuss this previously with regards to
computers and so on, because the IT issue, and actually I asked for that to happen because are you now being provided with paper rather than a computer? Well, that's at least something.
Just a moment, when we have our briefings, is David invited their teams meetings? Yes, they are briefings, aren't they? So
it might be something I can't recall receiving.
Oh, okay.
But I'm getting older, so I might be forgetting.
Okay, let me look into that for you. Because obviously you need to be included as a member of the committee. You need to be included in the briefings. Right. Sorry. Yes, Heather.
Something that's occurred to me very recently, because something horrendous happened in my village just over a week ago. Do you have a relationship to make sure that when we roll this technology out, which sounds really useful, really good, can keep working?
Yeah.
Well, for instance, half of my village has lost all its Wi-Fi, all its landlines, and constant bullying has meant that, yes, we've got a pole back, but we still haven't got a date for connection.
Yeah, sorry, when I said yes, I don't mean yes, you have the answer. I meant yes, I see where you're coming from.
And actually, if we're depending, which we will have to, and we do need to, because once you've got people with complex needs using the systems, if they go down, it's really traumatic for them. And I do regularly with somebody from my division who's got severe learning difficulties, and anything that doesn't work properly throws her completely. So we do need to have a good relationship to make sure these work with open reach, so that actually we can say this is really important and escalate them up. And actually my village was top category, which is 4, but still it took me doing Radio Shropshire, all the newspapers, to actually get a poll team back. And once you lose a poll, you lose everything. And this will really affect Shropshire Council if we can't get these things back in, especially in the rural areas. Now, it's not so difficult if you are providing these services in the more urban areas. But as soon as we're out in southwest Shropshire or any rural bit where people do live, then we have a problem. So there's a Connecting Shropshire link that we need, and there's an Open Reach link, which is an ongoing relationship. I'm also interested in looking at staff pay, because it is a big issue. And interestingly, Cornwall Council had a huge problem with staff pay, because every summer they were paid better in the tourist industry. So they now pay the real living wage rather than the minimum wage. Are we looking at that and the best practice that's happening other places?
Thank you, Heather. I think you're absolutely right about the internet and connectivity. That's a huge issue. The devices that these individuals use are mixed, so there's a lot of offline, thankfully. So all the prompts and all the verbal visual cues are offline, but absolutely a lot of them rely on it to video call family, to stay in touch with them, you know, to research where they're able to on the internet with the research activity and things that they enjoy doing. So I think that's really important. So I think that's a really valid point. And in relation to staff pay, we every year, as you know, we look at our annual uplift and the inflationary uplift that we did provide to our providers. Shropshire is one of the highest payers in a rural county of hourly rates to providers, and we model up the HCA rates against the rates that we pay to our providers and make sure that what we pay per hour allows the providers to passport that hourly rate onto their staff. We can't enforce them to passport that rate onto their staff, and that's where the challenge comes.
I was just going to ask, how do you monitor that? Because it's not what you pay the provider that I'm interested in, it's actually what the carer on the ground gets. Exactly. That I'm much more interested in. And does that equate to the real living wage? Because it needs to.
Yeah, exactly. And that's the challenge we have. We can't force providers to pay their staff. We can model our pay that we give to providers, like I said, that make sure that it does. And we can encourage providers to pay their staff that wage, but we can't force it on them. And that's where we're challenged.
can we have a report back on that? Can you tell us how many are actually paying what we intend them to get and what level we're intending them to get?
Yeah, we can certainly look into that. Yeah.
Kate, you had a question.
Thanks. And I mean, this looks overwhelmingly positive, you know, everything that you've reported on, and it looks like it's a really kind of valuable area of work for the future. I was interested in the Care Cubed package that you put together. You're doing a soft launch, by the sounds of things, and obviously you've highlighted quite a lot of positives there. Are you finding that they're introducing any new system that comes with its challenges? So I was just interested in hearing, what other difficulties you're having with this package, and are they things that can be overcome?
Yeah, so we're having some difficulties with accessibility. So the type of information that we're requiring to build into the system, and our own IT, what our own IT will allow us to use in terms of package. So we're currently working on that with our IT colleagues at the moment. Hence the reason we've not rolled it out through the social work teams yet. So at the moment, I've just got 2 staff in my team who are looking at our existing placements that we have people in, where we know that they're higher because we can download those reports, putting that information through the Care Cubed calculator to look at whether that placement cost is reasonable or whether there's things that can be done differently or negotiations. It's obviously challenging getting information from the providers, particularly at the moment, because they're all really struggling. There's a lot of information in there that at the moment is mandatory fields within the calculation system. So we're working with Care Cubed to look at whether some of it can be either pre-populated by provider or not required because some of it's repetitive. So for example, the Care Cubed calculator asks you to put in specific outcomes for individuals. So an outcome might be somebody to be able to start voluntary work, for example, and that's in the Care Cubed calculator. That comes with an additional payment. Well, because of the rate of pay we pay providers, we don't currently pay on outcomes. We would do that within the hourly rate of pay that we delivered anyway. So it's teasing out the little challenges that the system has and actually adapting it to work for Shropshire. And I'm quite fortunate that I've got somebody in our team who's very good at working on systems and has spotted lots of real opportunities for us. But we've got that challenge of working with the provider of the tech, which is Care Cubed, to enable us to be able to make those changes to adopt it for Shropshire so it works for us. So yeah, there's definitely challenges.
Are they being flexible? Because I have been involved in not this, but something similar, where it got quite difficult to actually negotiate those.
So we're still really early days with it at the moment. They're talking in the right language and that they're going to be flexible, but I think we're yet to see the proof of that, if you like, in the actual new design, as it were, or the flexibility in the existing design. So I don't have the answer to that just yet.
Thank you, Kate. Are there any further questions at all? No.
Just for interest, I've just put up, I've just put up the data because it was requested when we met at the briefing around the age range of the individuals accessing the technology. So as you can see, it is quite varied. As you'd expect, a lot of the younger individuals are accessing it, but we've still got quite a number of individuals between 40 and 60 accessing the technology as well, which is great. And much lower at the older age category between 71 and 80. That's quite often because we don't have that many people in supported living in that age category at the moment. So yeah,
I think that would be the interesting thing to actually see how many you have in those categories, because then it gives you a really good idea. Because if you have large numbers between 40 and 60, then you'd expect them to have
exactly. Yeah, it does reflect roughly I'd say 31 to 30 does, 40 doesn't, but you know, going into the over 60s, it reflects the numbers that we've got in those supported living schemes. So yeah.
Okay, are we happy? Yeah, no further questions. Right.
So will we get, I'd really like to know how you get on trying to build relationships with people. So can we have some sort of feedback on that?
Yeah, my colleague will be involved in that as well, because I specifically support the supported living provider market, which is much smaller than our dom care market and our residential home market. So it would be a joint piece of work which we can bring back, but definitely. Okay. Yeah.
Chair, just to inform the committee that there's a briefing coming up in 13th of October, I think, off the top of my head, around domiciliary care provided by the relevant service manager. So perhaps when we discuss the work programme later, you might want to have a think about how you incorporate that into your work programme going forward. So we do have some capacity to look at this in more depth if you wish to.
Thank you very much.
Thank you. Pardon, I can't hear you.
Sorry, there's obviously Stephanie's here as well to talk about the.
Oh yeah, Steph.
So she's online on Teams.
Steph is online to talk as well. Steph.
Hi, yes, my name's Stephanie Kelly. Excuse me. I'm the team manager for the occupational therapy team, both children and adults. And like Michelle, we did a presentation. I say we because that was myself and David Gregg from Private Sector Housing around the OT role and the follow-on to get adaptations into people's homes so as they maintain their independence for as long as they can and to reduce care costs ultimately. From a OT's point of view, one of the things that we are looking at is because obviously the numbers of older residents in the county are increasing and people are living longer as well. So we have to continually monitor and review the waiting lists. And one of the things that we've noted is that on the waiting list, there are some people who are waiting for what we would see as lower end pieces of equipment, such as perching stools or shower chairs. And it's a way of dealing with those very quickly so as they're not sitting on the waiting list. And we only have people on the waiting list who are needing bigger pieces of equipment or adaptations. So going forward, we're looking at the front door, which is FPOC, what we can do there so as we can sort of prevent these people going onto the main waiting lists and deal with those issues at the front door. So they would speak to either an occupational therapist or an occupational therapy assistant, and they would talk of what they needed, etc., etc. And a telephone assessment, if possible, would be done at that stage, and the equipment would be ordered and delivered in a more timely manner. Now we're looking at that at the moment, and the plan going forward is that we will be able to do something positive within that scheme of things. And looking at the referral pathway, a lot of the things that we learned from COVID was that you don't always have to do a home visit, that you can do a telephone visit, which we've continued to do. Virtual assessments, some of our children's parents are very keen on those because obviously they're IT literate and they can do those much easier. So that we're doing virtual assessments as well, and we're doing telephone assessments with photographs being sent in or videos from families that we speak to, but also where we can do a home visit, we do a telephone visit initially, so as it reduces the amount of time that we're in people's homes, so it maintains their safety and ours as well. And we're continuing to do that, and that's working really well at the moment. From a DFG point of view, a lot of our referrals are for people who need mostly major adaptations, but some minor adaptations, so handrails, grab rails, etc. So we work alongside private sector housing very closely, and a lot of our referrals go to private sector housing for them to do the disabled facility grant work and the other discretionary grants that are available for people to use based on what income they have or what savings they have, because the disabled facilities grant is means tested, and so we work alongside them as well doing that. And often when adaptations are completed, the OT will go back in and will put in pieces of equipment that were needed, like shower chairs or perching stools or things that needed to enhance the adaptation that's been done. At the moment, private sector housing are looking at their processes too, because they believe they're slightly cumbersome with numbers of paperwork. So it's looking at actually the amount of paperwork that both us as an OT team and private sector housing have, and whether we can make it more efficient and more timely, and less loaded with paperwork that people have to complete. We send a lot of letters out, and we're looking to see whether actually those letters need to go out, because actually we're just repeating ourselves, so it's not cost effective at all. So private sector housing are looking at that at the moment. They are also looking at their priority pointing list, which is the list that they use to get a threshold and a risk element, so as they can see whether people are at the top of the list or at the bottom of the list, and they're looking at that as well and updating that, because it is a little while since that's been updated. So there's a lot of potential change coming along within the OT team and the private sector housing team, and hopefully as we move forward we'll become more efficient and more user friendly for people, because often our people that we're dealing with are the older age group, and we need to be mindful to keep them as independent. They want to stay in their communities and we want to keep them there as long as we can, really. Is there any questions?
Yes, Kate.
Thank you, Councillor Halliday. I was pleased to hear your description of at the beginning of your talk there about perhaps allowing some people to get equipment more quickly, and I guess my question was around, I saw the presentation, I didn't actually attend it in person, but I watched recordings, and there was some discussion there about how you have a waiting list, and I know that you're doing what you can to reduce that, but you said that there was a risk assessment there, and those at highest risk would go to the top of the waiting list, and I think I've got that right.
Yes, yes.
Yeah, I guess I can understand why you do that, but I guess my concern was around some of the more preventative things that might, there may be someone who's doing relatively well, but might need something fairly small, could then prevent them from moving into a higher risk category. And I was just wondering whether you take that into account as well.
Our aim is actually to do more preventative work and to get to people much earlier than we're currently doing, and that would be part of the development we're doing at the front door, so as we can get to those people much quicker, so as they're not deteriorating while they're waiting to be seen. But the other thing to say about the risk assessment for the waiting list is that even though someone may be deemed as, we do it as in colours red, amber and green, as green, those greens are also travelling up chronologically, so they don't get stuck at the bottom with people coming in on the top as seen as more risky, because obviously what we have to be mindful of is those people who are green are also have a need, and if you leave them sitting there too long, they will then become more needy, and the prevention element is lost. So we're really keen to look at the prevention element of it all, and absolutely right, that the earlier that we can get equipment into people, the safer they are, and the more independent they remain for much longer. So that is key to everything, I think.
Okay, thank you. That's a bit of additional information as well there. That's exactly my concern, was that some people might end up just permanently at the bottom of the way.
At the bottom, yeah.
Right, thank you, Heather.
And that's good, and that's reassuring, but you're doing work on all of this. Do we have any target times around this work, so that we have something to measure for the future to say this is really working well?
Unfortunately, Laura, who's my manager, and I were going to have a meeting with the seniors last month, and that obviously that couldn't happen. So we've got it booked in for later this month. I would expect and I haven't discussed this with Laura, but to have a plan of action by the end of the year.
With the detail around the different sections.
With the business detail around, yeah.
Thank you, and that will be made available to us. Okay.
Yeah. Yes, definitely.
That's good. We shall look forward to that. A nice Christmas reading for us.
Yes.
Are there any further questions at all for staff? Yes, Gerald.
This equipment that we get for them, when they finish using it, do we store it anywhere or refurbish it, or what happens to it? Is it just a write-off?
The equipment provider we've currently got recycles all the equipment, so they pick up any equipment that's no longer needed, takes them back to the warehouse, cleans it, restores it, and puts it back on the shelf to be reused again.
Thank you.
Right, are there any further questions? No. Tanya, I don't know if there's anything you wanted to add. No. Great. Okay then, right, so we should move on to item 7. Oh, sorry.
It's probably the way that I work, because I was a teacher and used to be face-to-face in rooms, but I actually find it really difficult to follow someone when they're not on screen. So we couldn't see the last people, I couldn't see this, and so I actually finding my concentration wandering. So do you think IT might be able to sort it so that when we just have a verbal presentation, we can actually see them doing that on screen, because it would make a real difference?
Yeah, in other words, Steph, maybe you should have turned your camera on.
Sorry.
Because we've only just got a view of the room.
Yeah, no, if Steph was to turn her camera on, you would, well, I'd see it here on this screen, on the little screen.
Apologies, I was under the impression that the screens had to be off because IT were asking for them to be off, otherwise I'd have put it on.
Yeah, no, I think possibly because of the IT issues earlier on, I think that's probably why they'd asked for people to turn their screens off. But I think as the presenter, it would have been okay, but not to worry.
Okay.
I was assuming it's everybody else's fault, not yours.
Oh, right, okay.
Okay, point well made. Right, we'll move on to item 7, our work programme. Daniel.
Thank you, Joe. Let me just pull the programme up. Just a little rundown on what we've got lined up for October and November. The community support options and adult social care that I talked about earlier, the domiciliary care, is out on the 26th of October rather than the 13th. Then we have 2 items proposed for November at the moment. One around the new direct payments policy, and a perennial topic for this committee, health in all as well. In addition to that, I noticed from our conversations today that there were a number of questions which the CCG were unable to answer around the 111 service. And I do suggest, rather than write to them with sort of personal concerns, I think those questions are sort of more generally valid. And I think in the interest of good scrutiny and transparency, perhaps we ought to write to the CCG with a view to getting a written response, which we subsequently publish. So that would obviously be the agenda item going forward. I think as well that there are a number of people touched upon the links between, including the CCG, touched upon the links between 111 and primary care provision, particularly within GP practices. And I did wonder whether the committee might like to give some sort of consideration to how it might scrutinise primary care provision, particularly with regard to GPs going forward. It's not just this topic as well. I mean, I know that the subject of GP mergers, closures, is an evergreen topic for this committee, and there was the start of a recent consultation to amalgamate up to 9 GP practices within Shrewsbury into one super centre within Shrewsbury. So there are lots of topics there, of course, that are coming together that that members have raised either in the meetings or outside of meetings. So I would ask the committee to sort of perhaps give some thought to how it may or may not like to look at those going forward. So that's everything for me for the moment, Chair.
Thank you. Yeah, Kate.
Yes, thanks. I think that would be really interesting to look at how primary care is working. I mean, I made a request for the super hub wellbeing centre, whatever that might transpire to be in Shrewsbury, to be looked at. And I think we're going to look at it at the joint scrutiny health social care scrutiny committee, but I think it might be worth looking at it from this committee as well.
I'm not sure there are any plans to look at the Shrewsbury Hub within the Joint Health Committee, so this would be yours to take if you wished it to.
Well, certainly then, yeah, absolutely. I think that would be certainly creating a lot of anxiety amongst the public, and the plan seems to be very sketchy at the moment, maybe for reason, but I think it would certainly be good to look at that.
Alongside that, I've had a merger happen during COVID and lockdowns, which has been a complete and utter nightmare locally. So actually looking at the whole process, the way they consult, how they do that, especially if you think that you just give it to a letter to somebody who comes in, you don't actually communicate with the rest of your staff, how you actually merge it and all the practicalities around that so that people's prescriptions continue to be given out properly alongside the huge rise in appointments and so on. I think looking at what's happened to me locally alongside this one, which will be much bigger and much more complex, would be really useful, because the Worthing and Ponsonby merger has been, as a local member, has been a nightmare.
I would agree with that, and I would argue as well as members, it's far safer for you to look at this matter in its entirety. I mean, obviously, because you're local members, and obviously you have local campaigning to do as well. So it can be very hard, I think, for you to sort of split scrutiny of a topic to something that is actually very pertinent to your local area. I think by looking at it a lot more generally, it provides that space within scrutiny to do it without compromising your role as local members.
I think the other thing around it is to actually see what requirements are put in place by the CCG or NHS England or whoever. And I found it very difficult to find out. And so with one going on, to actually see a framework of how this was meant to happen.
Yeah.
And that would be useful for all of us, because it's going to happen across the county.
Yeah, I would agree. We had a briefing, a small presentation or a couple of documentations around the Super Hub, and I think I started the engagement process with the CCG around this, asking for some of the data that's being used to inform this service, and was passed over to a web page that just kind of said, well, we're looking at this. There was no extra information there. So I think rather than leaving it to that consultation process, bringing it in allows us then to start asking these questions. I do wonder whether it might be worth holding an informal meeting of the committee where we can sort of start bouncing these ideas around on how we look at this and the questions that we might approach, and I think that would then determine who we speak to and how we speak to this. I mean, the hubs, you know, if it happens, is a 3-year process. So, but I think really these questions are very pertinent now. So I don't know how you feel about perhaps starting the ball rolling with an informal meeting to just
certainly.
Yeah. Through. Okay.
Yeah. We can organise that.
Will do.
And that will be not a virtual meeting, or are you talking about?
Well, I was thinking of perhaps we could sort of hold a planning meeting virtually, with a view to bringing this to scrutiny first. So I think it's just a question of how we plan to make sure that we cover everything that we want to cover, because there are all sorts of topics coming in here around closures, around mergers, and around.
You need to make sure David is included.
Absolutely. Yes.
Yeah. Right. Thank you.
Leave that with me then.
Yeah. Okay. Any further thoughts on the work programme? Further comments?
At some point, we will have to look at the government's plans for adult social care. And it probably won't be that soon, but actually funding and all of that will be important to us as a scrutiny committee.
We'll have to declare an interest though, because we'll be being penalised like the rest of even if you're over pensionable age, you'll still be paying.
But it's a very valid role,
Yeah,
and
no,
we'll be waiting
agree
3 years for any sort of plan or any sort of money.
No, quite agree with you. Yeah, because the initial money is going forward to the NHS itself, isn't it, to catch up with the backlog rather than to social care. Yeah. Thank you. And that's it then.
Yeah,
that's lovely. Everything from everybody. Well, thank you all for attending, and I now call the meeting to a close. Thank you very much.